Now it's starting.
Um, Dear friends, our uh, webinar, we could not make a good connection yesterday, like last time, but we have very nice connection this time. Uh, Dr. Jesus Lafuente from Barcelona, Spain, will tell us cervical arthroplasty. Is it a gold standard for herniated cervical disc or not? We will very challenging discussion we will have, I think. Yes. Dr. Lafuente, we listen you.
Well, thank you very much, Mehmet, for the invitation. I'm sorry that we couldn't do that the day it was supposed to be, but as you said, the connection wasn't perfect. I think I'm glad that the connection now is good. So I will start on a topic that interests me very much, as my PhD thesis back in London was about cervical arthroplasty with the Brand disc, and I will show some of the results I did on my PhD. And the main question has been always if a cervical arthroplasty is the gold standard for all herniated cervical disc. And I hope after this discussion, we can come into a more clear answer to this question. I'd like to take, first of all, some anatomic considerations, which I think they're very important to decide the relevance of arthroplasty. Then I'd like to discuss some of its indications. I will go through adjacent segment degeneration, which has been maybe or perhaps the leitmotif of the promotion of arthroplasty. I'll touch on clinical results, technical issues, which I think are fundamental in applying and or putting in a prosthesis. We'll also have to discuss briefly randomized controlled trials. We'll go very quickly through complications and finally some of the conclusions. So when we talk about the cervical spine, we know that's the most superior portion of the vertebral column, lying between the head and the thoracic vertebra. It consists of 7 vertebrae, of one of which C1 and C2 are special ones, and are the subaxial ones in the spine, which we will be interested on with regards to putting or doing a discectomy, particularly when in C2, in between C1 and C2, there's no such disc. For me, it's very important when we talk about a substitute of a joint to discuss what are the joints we want to substitute. And when we talk about the cervical disc joint, we need to take into account that there are 2 associated joints which are very important indeed, particularly one. If we talk about the cervical disc, we know it's a symphysis, and we know that as a fibrocartilaginous joint allows a slight movement and also acts as a ligament to hold the vertebra together and also acts as a shock absorber for the spine movement. You have to realize that cervical spine is very mobile, and this mobility is thanks to the discs. But not only the discs are important, which are the ones we want to substitute, also the facet joint, the typical esophageal facet joint. Each facet joint has articular cartilage, synovium with synovial fluid, and also, as you can see here, this little meniscus. Okay, so it's a true joint by itself. And then we have a little one, which is called the Luschka or interuncovertebral joints, which are small, also synovial articulations. And I emphasize on the word synovial because all joints that have synovium within can be deteriorated by arthrosis. So these are the 3 joints which are involved with when we talk about a intervertebral segment: the disc, the facet joint, and the uncovertebral joint. So yes, arthroplasty has been very well discussed, particularly when Chanley, a British surgeon, and Ranawat, also British, did use this prosthesis to big joints. So the shoulder and the hip joints are ball and socket joints, as you know, and all they they had a problem or arthrosis on there on that joints, the solution was to fix that leg and into the hip, and that gave a huge impact on the normal life of the patients. Similar to the hinge type of joints as is the elbow and the knee, and clearly in these particular joints, arthroplasty has made a huge impact, coming back to work, mobility, life quality, etc. But is this the same for the cervical disc? Well, as we have discussed before, if we have a disc prolapse, which is a consequence of arthrosis with some sort of trauma or other aspects, the disc protrudes posteriorly typically, and we take the disc out and normally fix it or fuse it. Now, the arthroplasty you can use, but then you have to realize that the facet joints have to be like this, clean. If they are arthritic, like this one here, this disaster, as you can put a prosthesis in the front, but you will create movement where there was, and that will cause more pain. So sometimes when you put a disc on a patient and patient complains of more pain than they had before, is because maybe the joint, which is nearly fused, now is starting to move and is painful. So what are the indications to me? And this is what we discussed initially on the initial trials with Brian back in 2001. And I think it's important that the indications haven't changed much. A few things with sagittal balance and so on, but the main indications was soft disc, intact satellite joints, a good sagittal balance, good alignment of the cervical spine, and this occurs generally in young adults, that is before 50 years of age. If we have this case, for instance, you can see the disc protruding here. You can see a fairly good sagittal balance. I would give a green tick to this one, whereas in the contrary, if we have this is kyphosed, the disc is compressing the spinal cord, as you see, but putting a disc here will not make a difference, as you may not gain sagittal balance, and therefore, for me, this is a red cross. So how many of these discs may be amenable for a prosthesis? Maybe 10% of all cases. This is my experience by myself. So soft disc herniation, normally or traditionally, these have been fused through the operations of Smith Robinson or Cloward. Over 70 years with good results. Arthroplasty is more flashy. We talk about the joints, but you always have to remember that, particularly when the herniated disc goes foraminal, you have the option of a foraminotomy, a scobial procedure, which the preservation of the joint or the movement is the same or is preserved, and with the original disc, which is better than any of the prostheses there are at the market at the present. So this is a study from Holbert, a very clever study, which shows comparing anterior cervical discectomy alone with fusion through a bone graft and fusion and plating, the three arms of this study, a prospective study, randomized. And this shows that after 2 years, the results are perfect. They come from a McGill pain score from 35 down to virtually 2 or 3. And this is on the three groups. So why do we want to change an operation which works beautifully for something that we are not really knowing what are the effects of it? And there are many potential complications to it, as we will see. So why an arthroplasty? Well, people believe it will give you better pain relief, it will protect the motion, it will prevent from pseudoarthrosis, it will keep the sagittal balance, it will prevent adjacent segment degeneration, and it will prevent by taking bone graft from the donor side. I think this looks very good to me, and if you tell me in a consultation room, this is the benefits of an arthroplasty, and when I say me, I'm sure everyone will coincide with me. Everyone would like to have this prosthesis put in. Is this true? Let me show you some videos These are long videos. Let me see if I can make it work. This video shows the biomechanical stress produced when a fusion device is inserted. And let me show you. This is not working. Let me see if I can apologize. This is with a prosthesis. You can see the elegant movement and all the facet joints moving accordingly, okay, and minutiously. Perhaps we can remove this one out and use and show this one if we can. In the contrary, this video, we can do it. No. Well, there we are. You can see the superior disc due to the huge biomechanical stress produced above, and you can see how the facet joint subluxes more than it does in the other segments below. Okay, I repeat it so you can see it is very clear. Of course, not every patient is the same, but look at how the facet joint moves in that particular superior segment of the fused one. So now, sync. Okay. So what about prosthesis? I mean, you need high standards to show something that is now a new device that is going to have a huge of implications, and that you have to prove that this particular new device is much better than what we already have, which we know is excellent. So this involves biomaterial testing. We need to know that the material we are implanting is not damaging the body, and you do that by testing liver samples and blood samples and etc. Also biomechanical testing. You have to realize or make sure that what you are putting something for is actually working. It's going to be preserving the motion. Then you do it in animal testing. You do a clinical safety phase 1, and this is what we did in Europe, the European Consortium, and then you run into randomized control trials to prove whether one is better than the other in any of the aspects that you want to prove. So when you talk about motion preservation, you put the skeleton into these machines, and these analyze biomechanically the range of movement of the discs in a fused segment above or below, and on an arthroplasty segment above and below. So the results are, as we saw in the video, that the superior adjacent level develops increased angular motion compared to the preoperative range of motion, and this is on the fused patients. In the arthroplasty patients, the angular motion is similar to the one you did preoperatively. So clearly, there's radiological evidence that there is some preservation of the adjacent segment. So what we see in the fused segment is that this won't move. This is obvious. The adjacent segments, when you put an arthroplasty, when you fuse, they will keep the moving range, but they will be increased above and below, particularly the superior one. Contrary to the index segment on the TDR, on the prosthesis, will move generally a little bit less than it was pre-op on that same range. And all these studies have proved that there's clearly a statistically improvement when a prosthesis is done as expected. These are showing some studies with the PCM, and you can see when you put a prosthesis here, all the segments move equally, so there's an harmony in movement. When you put a plate or a cage, then some of the segments non-fused are the ones who are hypermobile, and you can see here the one which is fused with little movement or none. Then they have proved also arthroplasty in one segment, arthrodesis in the other. So where the arthroplasty is, there's hypermobility, and the other segments move equally normally. The fused segment doesn't move, and this matches for two levels in the same manner. So kinematic studies prove clearly that there's adjacent segment degeneration radiologically, and this has also been shown in lumbar, in patients with lumbar fusion. And I think it's important to see this is not only happening on the cervical spine, which is hypermobile compared to lumbar, but also in the lumbar spine. So this is a slide which is very obvious, shows the angulation or segmental angulation on the treated level. Those where they've been fused, there's no movement. Those with the prosthesis, you can see slightly below the normal range of movement preoperatively. So we go now to discuss adjacent segment degeneration, one of the hot topics on this and the reason why TDRs are still on the market. This was reported, the paper by Hillebrand, very important, a keynote paper back in 1999. He reported symptomatic adjacent segment on 2.9 per year in 374 fused patients, 2/3 of which required surgical interventions. Now, 374 patients, 409 procedures, retrospectively looked after in 20 years. Not only there were cervical discs, also corpectomies with strut grafts, 2.9 incidents of adjacent segment disease, 25 years using 25% during 10 years using the Kaplan-Meier survivor curve. The levels were more affected 5, 6, and 6, 7. Of course, they are the most affected because they are the higher mobility segments. Also, there was 12% adjacent segment degeneration in multi-level compared to 18% on a single one. This is also obvious because one single one gives you more segments to deteriorate, whereas if you do 2 or 3, then they're fewer. So this is obvious. And 27 out of 55 went on to surgery for adjacent segment degeneration. After this paper came out, the prosthesis got a huge impact, and there was a lot of excitement about this. And when I did my PhD thesis in Queen Square, we examined, I went through 687 cases after 10 years, and there we had ACD without fusion, clovards, Smith-Robinson, BOPs, which was a biopolymer material, which wasn't very good, and all of them had plates put in. All of them but the ACD without fusion, of course. We could saw 1 in 8, 30% of patients underwent surgery. Remember that all these patients had a bone graft extracted from the hip. But not only important to determine that we have 13% adjacent segment require intervention, but also the non-adjacent segment, there was 1.1% too. So segments 2 or 3 levels above the previously operated one deteriorated and had to be intervened. So that gives you an idea, perhaps, that although still unclear, is this adjacent segment degeneration or pathology or disease a natural progression, natural history, or is it a consequence of the fusion, or is it a natural phenomenon which is accelerated by the fusion? Perhaps this is more the case. So we examined this radiologically, and as I said and mentioned before, it was clear that motion rather than fusion will prevent symptomatic adjacent segment of this disease and will decrease adjacent level radiological indicators of disease at a 24 postoperative interval. And this has been shown in a huge study by Troinellis. Furthermore, there's another study by Mumaneni, also randomized controlled trial, and not only showed that radiologically there was less or incidence of adjacent segment disease on patients who had been with a prosthesis compared to fusion, but also Mumaneni claims that there's improvement on the neurological success in the clinical outcomes and, of course, on the reduced rate of secondary operations due to the less adjacent segment degeneration, which compares to the allograft fusion. And this is a study for 540 patients, so it's a very, very important study, this one. So we are touching very briefly on the clinical results, and for me, it's very briefly because for me, when you talk about the clinical results, they should be equal. I do not understand quite why are they different. I think there's clearly a bias there because most of these studies are financed by industry, because for me, when you remove the disc and release the pressure onto the nerve, this is where the results should improve. Now, you put a prosthesis or a cage which moves or a cage that doesn't move, I don't see why this has to do a lot on the clinical results. Maybe there are, but whatever it is, the results show that there are no statistically significance between one or the other, but with a slight trend towards the prosthesis. Again, I believe personally this is biased by industry. So let's see the study, what we did, looking at the neck disability index, comparing Brian to a plate. And you can see Brian did better. Neck pain scores also did better than fusion, slightly. Arm scores also, which is why I don't understand, because the nerve is decompressed either way. SF36 physical, SF36 mental, all of them clearly prove better on the Brian disc compared to prosthesis, but in that particular study, the one we have done, this was no statistically significance for any of these subjects. Now we have this other study from the Prestige, which you can see is a less elegant prosthesis compared to the Brian. And here, if you see the results of the Prestige and Fusion, these are the Fusion, this is Prestige, a slight trend towards better improvement, particularly on the last 12 and 24 months, where in this occasion, this was clearly significant or statistically significant in 12-20 months. And this is the overall success comparing similar one and the other here with no statistically significance of whatever. But now we compare this to another study from the PRODIS C, and we see that there's no difference at all here. So the ACDF and the PRODIS produce the same results. So this brings me a question on, are all the discs created equal? Or are all the surgeons equally meticulous? So these are two concepts which for me are absolutely crucial when we discuss the results. So these are a graph showing the different prostheses with different design. The articulation, one is biconvex with nucleus articulated with end plates. The other one is a ball on socket. The other one is three-piece disc with biconvex mobile core. Not only that, they have different constraints and different center of rotation. So we have a high variety of prostheses with different technological issues, none of which has shown particularly that is better than the other. And this also brings a lot of controversy on the prosthesis. We had only one prosthesis and we stick to this one and we compare that, that will have much consistent results and that will show whether or not the prosthesis is better than a non or a fused graft. And this brings me, when we talk about meticulously on the surgeon's technical demands. When we do an ACDF, this is easy. We decompress, we remove the disc, we drill the osteophyte if we have to. We can even drill the umbilical joints. We open the posterior ligament, we remove the disc fragments, then we stabilize, reconstruct. We can put a lordotic cage, we can realign the spine sometimes. We have several options. But now, if you put a prosthesis, this is a much more technically demanding procedure. And because you need to preserve the uncinate process, about 20%, you are allowed to drill up to 25%. More than that may create instability. You have to locate the prosthesis midline because the vector of forces have to fall down in the same line. That's why I don't like two-level prosthesis, and I will tell you that later. Now, do you remove the posterior longitudinal ligament or you preserve it? Now, you open the anterior one to put it in. So if you do not have a prosthesis with screws like the Prestige one, which acts basically as an anterior ligament, if you only remove the anterior ligament and preserve the posterior one, this will be an open mouth effect. So you can, the prosthesis will not move freely as it will be conditioned by the fact that behind is compressing and in the front is free. So constraint versus semi-constraint, again, a different issue. Let me show you, and let's see if I do this better now, a very interesting video. This shows the force required to get into the, let me see, it's a nice video, perhaps I can try it again. Bear with me a second, please. There we are. So this is no, we want to go back to the normal disc. There we are. This is hold on. This is the normal disc, and this is the curve of a range of motion and the force that requires to get into the center. So let's see what is the range of motion with a normal disc, and you can see that the vector for a neutral zone is very limited. Now try the M6, which I believe is a very good prosthesis too, and you can see similar with a slightly large neutral zone. But if you compare this to non-restrained discs, the neutral zone is hugely increased. So clearly, the more unconstrained there is, the more force the prosthesis has to do to get into the normal neutral zone. So I hope this is... So we have the prosthesis which act like a simple plate, and we have the Bristol biomechanic, we have the Winch PCM, Cervitec, or the Cervical. We also have as simple as a cage, and we have all this. You can see the Discover, Discoserve, M6 prosthesis. M6 is very similar to the one in Brian, I think, and I like it particularly quite a lot. And there's explosion of new devices. Of course, they've seen the economics of this, and they believe with the adjacent segment degeneration, there is clearly an indication for this prosthesis to be present. And the second generation also address the easy of use, the MRI compatibility, one of the things that I've been struggling with the first prosthesis, of course the materials, now to try and put them on kyphosed spines by creating certain degree of lordosis, the mechanism of fixation, also biomechanics and economics important. So talking about the RCTs, and I don't want to go long through this because the time is about to finish, but let me tell you about some of the studies, and these are the most important ones. The RCTs FDA directed with the Brian, was in China for Brian, Prestige. It's important the numbers, also it's important the follow-up percentage and how long the follow-up has been. I like to touch on the FDA Prestige, 60 months, and the FDA Brian, done very, very meticulously, very thoroughly. And of those, the first one, the Brian, TDR reoperation rate 5.5% versus Fusion 6.5%, non-statistically significant, whereas the Prestige 5.6% on the TDR, 10.2% on the Fusion, clear trend, but not statistically significant either. Let me show you, this was one of the issues we talked about before, is every prosthesis the same? And this is a very elegant study than comparing ProDisc and the Brian disc. Of course, the numbers are very little, and I can't evaluate the real significance of this cohort, but I think it's interesting to see that comparing these two prostheses done by the same surgeon and with a follow-up of 80% clearly, the radiological assessments for radiological adjacent segment pathology proved to be 7.9% on the Brian disc versus 8.8% on the Pro disc. So very similar. So, but still differences. Of course, there are other issues like the patient age, matching, and other things. What you're talking about, less than 1%, is difficult to consider this as significant. Clearly wasn't there, but gives you an idea that different prostheses work differently, and not every patient is exactly the same patient. So we come to a Cochrane review, and this is being reviewed in 3,160 patients, and it's like, I'm happy to say that the conclusion is very clear on that prosthesis is effective as an ACDF and superior in some of the outcomes. But the disc replacement does reduce the risk of adjacent segment degeneration, disease, but continued uncertainty remains about degeneration of the prosthesis. So long-term surveillance of these patients who undergo prosthesis has to be met, and we are now talking about 15 to 16 years since these prostheses were implanted. This is some of the conclusions. Low to moderate quality of evidence that results are consistently in favor of arthroplasty, although there's no statistically significance in between both of them. And these are some of the studies which again show that slight trend onto the arthroplasty, but with no statistical significance in these huge trials and randomized, very, very well respected authors. So I just wanted to point out briefly, if you different sort of as a matter of a sentence, to see how things are with respect to adjacent segment degeneration. So several multicenter randomized trials, different prostheses, more than 1,000 patients reported that less operations with arthroplasty. Another review from Botello found no evidence between one or the other. So recent meta-analysis didn't show any significance between arthroplasty and arthrodesis, and the incidence of adjacent segment disease for a prosthesis was 8.8 in the prosthesis side versus 30% on the ADF, with no clinical or statistically significance. And again, something that I like to address, mixed evidence for level 2 studies. One trial said there was no revisions for either group, and the other trial, the PRODIS, said, well, 1.9% revision on arthroplasty patients versus 8% on the fusion patients. So this gives you the variance of the surgeon, the technique, and also, I'm sorry to insist, the bias produced by industry, which they, of course, don't want to publish unwanted results. When you see other studies mention that 4.7% of the ACDF patients have to be revised compared to 2.8% of the ACDFs. Now, with supplemental fixation. We all know that. No arthroplasty have to be revised. But when do they have to be revised? Is the revision, looking at this paper closely, many of the operations or reoperations in the fusion patients are related to the graft extraction area. So you need to be and match exactly what you need to do. Remember that the randomized trials in the US compared prosthesis versus the standard, the gold standard, which was a graft from the hip and plate. So we have to realize that some of the results were biased by the fact that the hip also produces pain, and people with the hip stay 2 days longer than the 1 day longer than the one without. So this has not been put into the study, and this creates a conflict of interest. What about return to work? Well, again, PRODIS trial said there's no significant differences. The Bryant trial says you go 13 days earlier. The PRIST trial says that overall shorter waiting to go back to work with the arthroplasty. Again, length of stay the same. So what are the conclusions that we get from this? Difficult. So I think it has to do with the surgeon, with the patient will to go back to work, and many other aspects we don't take into account here. Just briefly, hybrid surgery. This is from a colleague of a friend of mine, Andreas Demetriadis from Edinburgh. He tried 5, 6, and 6, 7 hybrid, and although there's no quality of evidence still yet available, I think it's a good solution or a good option when your gut feeling tells you that perhaps one of the joints has a better, have suffered, the facet joints have suffered less, and therefore you can try and put a prosthesis there, so you distribute the biomechanical stress between the normal segments and the prosthesis implanted one. Now, we all say, oh, well, we don't have complications with the prosthesis. Well, certainly there are, subluxation. I have heard about tetraplegia on 2 patients. I've seen small fish mouth effects with this one, with osteonecrosis, some slump here, also pseudoarthrosis with the implant, which will protrude, patients, subluxation, breaking of the system, and then perhaps one of the messages I would like to pass is be careful what you do. These are human beings, and gut feelings is good, but sometimes can be criminal. So be careful. This is a fish mouth effect. Here the posterior ligament wasn't open, the anterior was, therefore the limitation of the movement, of course, is very small. So when you try these flexion and extension views, you will see that the movement range is virtually 2 or 3 degrees, which is not much. This is also ossification of the prosthesis, and we knew about the heterotopic ossification in TCI and TCA, and we had managed this with aspirin for 3 weeks. This was about 10 to 20%. Not only happened in Brian, contrary to what people believe, there were many prostheses that had this effect, and my BU is because the indication is wrong. If you have the facet joints already fused from the start, then it's going to fuse anyway. So you have to select the patients very carefully. Then there's also tremendous or very damaging complications as a posterior avulsion to the fracture to the adjacent segment of the vertebral body, which cause tetraplegia in a patient. Luckily, these do not occur very often. Segmental malalignment, and this is what we're talking about fish mouth effect. Does it occur? And this was described in the Brian disc. But also look at this one. This is a tool level with a keel prosthesis, which not only broke the one below, but also he broke the one above. And this is not, I would not criticize the surgeon. I don't think he is too rough. Perhaps he was. But certainly this is very abnormal and a very huge complication, which has to change the operation completely. You have to fuse this patient front and back, which is a huge undertaking for something as simple as remove a disc and put a little cage. Again, brave surgeons, brave colleagues want to be famous, and they say, well, I have a Klippel-Feil syndrome patient, I have only one disc alive, this has a prosthesis, I like to put, this got a disc prolapse, I'm going to remove this disc and I'm going to put a prosthesis to maintain movement on that area. Well, I think this is a big mistake. I know maybe some of you have more experience on that, but the common sense says that if you have only one disc and you put a prosthesis, this will fail invariably because the amount of pressure and strength and force that disc has to take is not been, this prosthesis has not been prepared for. Certainly, it will not be tested on the biomechanical routine biomechanical tests. How about the two levels? I never like to put two levels. I think the prosthesis is ideal for one level. You have to put it cleverly because look at these two levels. This bone is completely gone. This has to be changed into a corpectomy and a bigger operation. This is not acceptable either. Look at the scoliosis, partial scoliosis produced. This is brave, but I don't think it's clever. This is how it will look, and I think in this situation, I think it will be the best of the indication for a two level. And again, I say I do not use it regularly. And when we talk about cost effectiveness, well, a lot of studies have been trying to push TDR. We know that the market in industry for TDRs in the US particularly is huge, multi-billion market. And of course, if they say, oh, they will save $6,547 dollars on a patient, then clearly the manager of your hospital will try and push you onto inserting these devices. We need to be honest and do whatever we think. Just to conclude, ACDF for me still remains gold standard for cervical disc disease because covers all. You can put it on any of them with arthrosis, cervical spondyloarthrosis, whatever. This will cure the patient, take the pain out of it, and if you do one level, the range of movement sacrifice is not much. The TDR has also a very good position and a gold standard as treatment for cervical disc in patients with the right indication, which they are, and there are many, but you have to use it there. Natural history of cervical spondylosis is difficult to predict individually, therefore you cannot make assignments on what you're going to do or what you're going to be best for this. Look at the joints, make a good call and do whatever you think is best. Adjacent segment degeneration occurs in both groups, which indicates that maybe there's a point on natural history. And the trials have some trend towards the prosthesis, but not conclusive. Complications of prosthesis are generally iatrogenic, produced by the human, the surgeon, and could be avoided if a right indication and with a special technique. So going back to the adjacent segment degeneration phenomena, has to do with surgical handling, is biased by investigations by surgeons, has to do with characteristics of the prosthesis, and also with the natural history. I don't think the definitive TDR has not been invented yet, but I hope these are the first steps to produce one that will cover perhaps in the future and be the gold standard. Thorough with the correct indications would be my recommendation. You have to use honesty and professionalism. We are all surgeons, great surgeons. We don't need to prove it to anyone. So this is not, of course, it's not a case. This is a thing I have done myself, so don't be scared. But I'm sure some people I've seen with 4 discs, and I think this is not acceptable. So as a friend said, every edition of True Knowledge is an addition to human power, and I think passing on the message to the people who want to start doing this is as important as doing the operation. The correct indication is mandatory. If you want to be clever and do more than your neighbor, then you will end up with problematic patients, and you will not feel happy about this. Thank you very much to all of you for listening, and I hope we can enter a small debate, and hopefully my talk has been of some use to some of you. Thank you so much.
Thank you, Jesus. Yeah, very nice, very informative lecture we listened. First of all, the participants are asking questions by writing on the right bottom side. One question is that, is arthroplasty possible for more than 2 levels? Do you ever
Well,
try?
for today, maybe French. Listen, everything is possible. Everything is possible. The question is not if it's possible or not. The question is indicated or is not indicated? For me, it's not indicated. Ramon Navarro, a good friend from the Emirates. It is difficult to choose with the amount of devices available. What would you go for, constrained or non-constrained? I will go for the M6, which I believe is a constrained prosthesis. And I think, as I said before, we do not have, or there's not invented the correct or the perfect prosthesis yet. I think constrained gives you a bit more limitation of the movement, but I think is safer for the patient, and I don't think causes any damage for him.
Okay. I have one question that the heterotopic ossification looks like a phenomenon that the body itself try to preserve that level, actually try to restrict the movements at that level. But with the arthroplasty, we are doing what is against the nature.
Yes.
What do you think about this?
Exactly, Mehmet. I don't think, well, I think, yes, I showed in a slide that the body tends to fuse when something doesn't work. And this is the natural history, and this is how works, how the body works. That's why I insist that if you have preservation of all joints, you can put a prosthesis with certain guarantees that this will continue to move. If you have damage or arthritic joints, the uncovertebral joints are not as important, but also if you add on those, well, if you have everything with a very small space, discal space, plus arthrosis on the joints, if you put a disc, you will produce pain where there wasn't, movement where there wasn't, and also, eventually, the body will beat you onto that because the facet joints will fuse, and therefore the disc will not move and fuse ultimately.
Okay, one more question from Dr. Petra is that in your daily practice, do you do more fusion or arthroplasty surgeries? And are patients reluctant to try arthroplasty?
Mira, look, I personally do about between 40 to 60 discs a year. I do 3 or 4 arthroplasties, single levels. Sometimes I have 6, sometimes I have 10, but I tend to choose the right indication. It's not the number, but roughly I tend to do much more. That's why I said that the gold standard remains anterior cervical discectomy with fusion. But certainly on those young patients with preserved sagittal balance and good soft disc with good joints, I'm happy to put a prosthesis, and not happy, I indicate a prosthesis. And sometimes, following the question, patients will demand you to put an arthroplasty, And I had one particular patient that I said to him, I would not do this. He went to another doctor, he had an arthroplasty put in, and he came back to me saying, oh, yes, you are right. I had to have this reoperated and fused. So we all have our own book of tricks, but I think if you are honest and you follow what you've been taught, I think you shouldn't, you will always miss one or two patients, but you should miss very few. Farooq,
Yeah.
I don't understand the language.
Yeah, this is Turkish. I will translate you. In case that after an arthroplasty, a displacement develops, and if with this displacement and neurologic deficits happens, what is your revision strategy? What do you do?
Well, I had to do one, not for me, for another. I've done only one, because I have been lucky and I haven't had any major disasters. But I had to remove two. One was a patient that had a Galileo prosthesis, which was this recommended. I put it on a patient. The prosthesis on the patient was all right, but I had to remove it by instructions of the commercial industry. And at that time, what I did is open it up, drill it out, and take it out, and put a big lump of bone. It wasn't a corpectomy at all. It was only maybe 2 millimeters. The end plates where I had to go because they were integrated, and I had to put a big piece of bone and a plate. The other one who subluxed and went into the canal, I had to do a corpectomy. I think the mission on that is to try and regain some of the neurological function, and I don't care being aggressive in those patients, and I try to take as much bone as I can. So if I have to pull, I have a lot of space, and I don't pull against the spinal cord. I pull it against me, and this is what happened. Patient recovered some. It wasn't normal, but this patient changed Asia C to Asia B, I think.
Yeah, well, so in summary, we can summarize that in case of displacement of the material, arthroplasty material, the revision must be a fusion surgery. Is it? Am I right?
A revision surgery, yes, of course.
Yeah, okay. Dr. Ken Yonemura is asking, he had a recent case with a cobalt chrome allergy. Have you had any case of metal allergy?
Well, I haven't, and it's funny that you mentioned this because I heard a second case. Somebody mentioned on one of the meetings I went of the same cobalt chrome allergy. Very usual. I never had any allergy on that, and I haven't had to remove or revise any of the cases like this. But I understand that's why it's so important that you are putting some material there that he has to be tested. Let me say one thing because this question allows me to introduce this. When Brian did his study, it took like 10 years. He started with biomaterial testing. He put the prosthesis on animals. He then sacrificed them, analyzed liver, analyzed spleen, analyzed to see to the deposits of the titanium to be safe. Then he went into goats, and then he went into chimpanzees. Then he went to clinical trials. So this was 10 years. Now my impression is that the people do prosthesis and they do not go through the same battery or high standards that I mentioned initially in the talk with regards of testing biomaterials and looking at what the degree of allergies. I'm sure there will be minimum, and the cobalt and the chrome has been tested in many other prostheses, particularly hip and knee joints are made from that. So I'm sure, and they're bigger. So, but certainly I think there's a lack of high standards when looking at the tests that nowadays are being done with this prosthesis. I think they only stick to biomechanical studies and they don't do biomaterial studies.
Yeah, yes, sir. What about the cervical spondylotic myelopathy? Do you ever do arthroplasty in those cases?
Well, negative. Sorry. Of course, if there is an acute disc, in a young patient, yes. But for me, it's not myelopathy or radiculopathy. For me, is preservation of the satellite joints, which indicates that you can put the prosthesis. It's a fantastic operation, and the patients do great. Honestly, they do very good. And my impression is they even do better than the others. But then maybe I am biased by the fact that they're younger than the other patients. So it's very difficult. But of course, myelopathy, acute myelopathy for an acute disc, yes.
Well, okay. Okay, Onur, do you have any questions?
Lafuente, thank you so much for your nice presentation. I have two questions. First of all, you have told about the indications. There is a good sagittal balance. One of the indications is that. Do we have more details about it? I mean, are we have to take consideration for C2, C7 SPA, or is there any knowledge in the literature about do we have to take care for T1 slope, or do we have to take thoracic inlet angle? Is there more detail? Because it's a good point about the cervical sagittal alignment. And this is the first presentation that I have heard about indications about the good sagittal balance. And and after the answer, I'm going to ask another question.
Okay. Well, thank you for the question. Yes, this is very interesting. Now, sagittal balance have shown huge impact, particularly at the thoracolumbar spine. And if it works in the thoracolumbar spine, why doesn't it have to work on the cervical spine? What I mean is, biomechanically, a prosthesis is much more demanding than a fusion. So if you're going to fuse, doesn't matter if the patient has inverted or kyphosis or whatever. It will stop the movement, it will stop the pain. But if you have a prosthesis which moves flexion extension, some translation, some lateral, if you have a deranged spine or a kyphotic spine, then you are limiting already the movement that you will achieve when you insert this prosthesis into the neck. So what I mean by sagittal balance is basically segmental sagittal balance. If you have a kyphotic 2 levels above, I don't care. I will put a prosthesis 2 levels below. This is not normally the case, of course, but I don't look at the sagittal balance. I look more to the lordosis of the cervical spine. Preservation of lordosis is for me better than what we call sagittal balance. Sagittal balance, you need to do it from the whole spine. And perhaps it's not the right wording, but maybe I meant to say more lordosis rather than sagittal balance. However, if you have a sagittal balance of the spine, you have an unbalanced spine with a normal lordosis of the cervical spine, that now studies showing that this is also a bad indication. So that's a very well brought question.
Yeah. Okay. It gets me new ideas about the cervical sagittal balance and using the cervical arthroplasty. And the second question is, in the complication part, you have showed some cases there. I think they're from literature there.
Yeah.
They have used also cervical arthroplasty and also used ACDF. What do you think about it?
Well, listen, I don't like to say this because I feel proud of this, but I was one of the first that we started with Ramon Navarro, in fact, which is attending one of the speakers. He's a good friend who is now in Emirates, working in doing very well there. But we did one of the first cases. We thought that it makes sense that if you have increased biomechanical forces in the level below, why don't put a prosthesis below, protect that movement, or above, doesn't matter, wherever the joints look better, the facet joints look better, and then do a fusion. Sometimes you see a disc which is completely collapsed, and another one which has made an adjacent segment before operation. You know, the natural history is a few segment above, which is already collapsed, and above and below has caused a disc. For the disc, you put a prosthesis, and for the one below, you want to remove the already fused disc and give a bit more extra space, or maybe drill the osteophyte posteriorly. So I think there is an indication for it. However, the indications are not very much, and in order to get a large series to make some statistically significance, is going to be difficult. But of course, gut feeling from a surgeon with experience also is good, I think. We have to be very careful.
Lafuente, thank you so much for the very nice presentation. Thank you so much.
Yeah.
Thank you.
It was a great talk and very nice discussion, really. I think we should end it here. It's almost 1 hour. I thank you a lot for making it possible, and I thank all the participants for coming to this webinar.
Well,
Okay.
thank you, and apologize for the other time not being able to do it. I hope the message has come through, and
Yes.
I hope you can enjoy this beautiful surgery and become better surgeons. So I think that's the point of making these nice webinars, and I'd like to thank you, Mehmet, for being an inspiration and being such hardworking to make this happen. And I think you're doing a great job in the WFNS spine section. Thank you so much.
Thank you. Thank you.
Thank you.
Good,
Thank you.
Good night, everybody.
Good night.